Assalamu alaikum everybody, and Assalamu alaikum, the organizer of this wonderful workshop. We've had few lectures in the beginning from patient selection, preparation, counseling, advantages and disadvantages, and limitations. And I think counseling is very, very important. For example, we need to, as a consultant, have to decide that we are not treating an X-ray, we're treating a patient. What are the limitations? The patient has come from Mirpur Khas, Nawab Shah, Kankot, Mithi. Do they have an English commode? So, producing a pretty looking X ray is not our target. Improving the function, the life of the patient is very important. And this procedure is not for one day, 1 week, it is for decades. Ideally, we should aim that our procedure should last at least 2 to 3 decades. And this is how the previous lecture of approach, positioning is important. And today in this workshop, we are going to use the technology, but must understand that technology is not a replacement of basic surgical principle. If you don't have the skill, as Badr has said about approach and Nasir has said about positioning, your technology is not going to help. The technology is going to help the surgeon for precision in positioning the implant and reduce complication. Sir John Charnley produced the most successful hip arthroplasty, and that was a cemented total hip replacement. If you look at the literature, done correctly even today, the cemented total hip replacement is going to produce as good a result as any uncemented, especially on the femoral side. But then you have to follow the principle of the implant design and cementing technique. So on the femur side, a good result is going to be a polished tapered stem. And the cementing technique is first generation, second generation, third and fourth generation. So what is a good cementing technique? It is the preparation of the femoral component. It is pulse lavage. It is cement restrictor and using cement through pressurized gun. So this precision is going to improve the survival of femoral component, and you do a literature search today with the registry data. The result of a good cemented femoral component is as good as any uncemented femoral component. So I'm not saying that uncemented femoral are bad, but then it is the technique that is important. On the acetabular side, the result of uncemented acetabular component are far superior than a cemented femoral acetabular component. So you need to know the track record of that particular implant as well. So not every new company that is showing you a shiny implant, you should jump and using it. I've used Charnley implant and I'm seeing the outcome still follow-up of 20 years survival. And finally coming to the bearing surface. What is the best bearing surface? The bearing surface can be divided into hard and hard bearing surface and hard on soft bearing surface. Sir John Charnley started with different experiments from Teflon to high density polyethylene and now more commonly highly cross-linked polyethylene. So the best bearing surface is a combination. The best bearing surface is one that is going to last your implant, and the target should be 15 to 20 years. The best bearing surface to reduce wear is ceramic on ceramic, but it's a very expensive implant and it's got its own complication. For example, squeak and fracture. So my preference is hard on soft bearing surface. And on the soft side, it is the polyethylene and highly cross-linked polyethylene, especially with vitamin E, give me a very good bearing surface and it will last for 15 to 20 years. And on the hard surface, we can use a metal head or a ceramic. So the literature is important, but you need to see what is practical in Pakistan, in your institution, in JPMC, or a private sector that you're working. So we have to have a balance between the durability and affordability. But even if you put the top quality implant, and as Dr. Nasir has said, that your positioning is not correct, then the best implant is going to fail with dislocation. The other important aspect is you've put a best implant in correct position and you've used navigation, but you've not been able to reduce rate of infection, then it is going to be atomic bomb disaster for that patient, that institution, and the credibility of that operating surgeon. So all aspects of surgery are important. So preoperative planning is important, preoperative implant selection is important, placement is important, and obviously at the same time, the OR system and the OR discipline is extremely important. And prevention of this infection is something which is very near and dear to me for long term. So when you do selection, what is available? I know an implant is very durable, very successful, but unfortunately, it's not available in Pakistan. An implant that I've used for 20 years, and I'm very happy with the outcome of that implant in a knee replacement, but it is not available in Pakistan. What is the next best alternative? And then I do a lot of revision surgery, and you need a more complex implant. Unfortunately, it is not available in Pakistan. I had faced this problem 25 years ago, and I'm still facing this problem today. So we need to have our own solutions. So arthroplasty is never an emergency surgery. It's an elective plant surgery, and you should never shy in postponing the surgery because the range is not available. Don't go for elective surgery if the implant vendor is saying, sir, 48 का कप नहीं है और 52 का कप नहीं है. आपने कुछ ना कुछ तो लगा देंगे. ये हो नहीं सकता है. Arthroplasty is precision. Arthroplasty is perfection. Arthroplasty is long lasting. Thank you very much. If there are any questions, I'll be happy to answer.